Hello? Can you hear me? Hello? Hello? Yeah, you want to text him real quick? Oh, wait.
Nicole,
to meet
good to meet you. Hi, this is Becky, Dr.
Hi.
Denellen.
Nice to meet you.
Becky is one of our engineers who happens to live here.
Oh, cool.
So she kindly agreed to come in and play our computer. And she knows the space. I think that it'd be good for her to curate the questions while you and I are busy. If you want to curate the questions, there was a suggestion that Gretchen made over the internet. I thought, well, since she lives here.
Yeah, absolutely. Go for it. Whatever you want to do. Oh, yeah, because they said that they would, like, if there's the, because there'll be the online people, right? So,
Yeah, just let me know what I need to do.
This hybrid thing.
Yeah.
it's crazy. Well, especially because the other person, they're trying to troubleshoot that because I guess Zoom just crashed on this. So the other presenter is actually.
Hello, can you hear me?
So it's one thing for us to try to get ourselves
Hello?
out to the virtual world, but it's another thing to have one of the panelists be virtual.
Yeah.
But you know,
So you're a robotic.
I am not a robotics
Are you
surgeon,
sending
no.
it?
Which is
What
kind of
channel?
hysterical about this entire thing.
Zoom.
I mean, I am
Check
a
one,
minimally
two.
invasive guy surgeon, but I do not use the robot.
Whoa. Oh.
I use straight stick.
Check 1, 2. Can you hear me now?
But,
Hello?
uh-huh.
Hello, can you hear me?
It just crashed.
Uh-huh.
I've always, you'll hear, I've always been really excited about the robot.
Yeah.
But it's just such a pain to work with that it hasn't been
Yeah.
worthwhile.
Well, and I think that, like, you know, the evil empire of intuitive, so to speak, is coming down. Like, it's good because there's a space for it in the competition, you know what I mean? Like, and that's what you need to drive, you know, more technology, and then obviously it'll drop the price, which is a huge thing right now, right?
Right.
So yeah, I think
Did you
it's,
see the hominus?
no, I haven't seen that yet.
Oh, that was at the AGL. think
I
it was-
saw, it was, I didn't see, I saw, yeah, I know, I was just playing around, I went to the simulation thing, but I didn't go to any of the robot, like,
Oh,
stuff in the,
okay.
it's just not my thing. But it's okay, which is kind of hysterical, because when they reached out to me, the planners, like, a while back to be like, hey Nicole, why don't you look at some of this like technology? I'm like, well, that's great. I mean, so I just picked out stuff that looked cool.
Well, good. You were
Yeah.
glad you picked us up.
Yeah, exactly.
Because we're, my background is
You're a general surgeon, right? That-
and I started doing laparoscopy in 1990,
Uh-huh.
and then I taught in the Air Force.
Uh-huh.
Taught
Right,
laparoscopy
yeah.
in the Air Force, and then after a while, I realized how hard laparoscopy was for some systems.
Yeah. Yeah.
It was like they're great open surgeons, and they struggle
With that.
laparoscopy.
Right.
And then other people sit down at the robot and they're like, oh, my eyes are. So there's certain.
Yeah, there's a role for it, for sure, yeah. Yeah, it's hard with, it's funny because the few times one of our program, Ted Lee, our program director that I trained under, now is my partner in the past 10 years, he used to try to get us on the robot just for exposure, you know? And the problem is I would like use, rather than like, I think there is a translation to like the oncs that are like great open surgeons, and I was like, but I was trying, we do suprapubic port, so I was like trying to like load the needle the way I would do it like with straight, so you know what I mean? Like I was translating all of my laparoscopy knowledge to the robot, which isn't like how it works, you know, and I would just get so frustrated, like, I can't handle this. Yeah, so it is interesting, yeah. Because you almost have to unlearn, we always say like the best robotic surgeon is probably like a high volume OBGYN resident, like someone coming from like a great program like Magee that knows the anatomy, is safe, has some good straight stick training, but hasn't like gone to the, like for us as fellows, like we've gone to the next level and we have a system of how to do our advanced endo cases and our bowel work and all this stuff. In that way, you almost have to take a step back and then reintegrate into the, because the way we approach a pelvis with our straight stick is not the same way you have to like approach it robotically.
How do you
Yeah.
approach it with a straight stick?
Well, because we use a suprapubic port, and so having the suprapubic, I mean, I know you can put your ports everywhere, but
But your suprapubic, there's one suprapubic port and the other is
one,
suprapubic.
two lateral, and then we use a lot of suction irrigation for our dissection, and it's just like that level of operating is a different. I mean, I've seen like Arnie Avincula, you know, in his videos, and he's like a guru, like master robotic guy surgeon, right? But his approach, like the way he does it is slightly different. You know, it's not better or worse. It's almost like, as our trainer, I have to take a step back and totally pivot, as opposed to like the resident that's kind of on a trajectory, you know, that they can apply their safe skills and then to the other platform. I don't know. It's just. So.
Well, do people have people here who do surgery?
I don't know. It's a good question. Who the heck knows?
Let's see if I can get my slides going. Where would I put my slides?
Could probably ask the gentleman.
You ask them if you can get on your key laptop.
See the questions?
Okay, and then,
Can you hear me?
I can hear you. Can you hear me?
Yes. And you can see me too?
Yes, I can see you.
Perfect.
So Dr. Malpani, he's going to go first, and Anand is going to go first. Is that correct? Okay. And each of you have about like 20 minutes of content?
Yeah, I think I can squeeze it into 20, or probably a little bit of
Okay.
I don't think we'll go over.
No, I figured what I'd do is I would just introduce him, have him do his thing, then I'll introduce you, have you do your thing, and then we'll do the questions at the end. If that makes sense for everybody, as kind of a dialogue.
Yeah. Should I test my slide, like screen share as well?
And he's going to go first.
Yes, I just found out you're going first. So if you want to share your screen, I'll put you up on the screen here.
All right, 1 second. All right, I'm sharing now.
Yep.
And we see you here, and we hear you clearly.
Perfect. All right, I'll stop sharing then.
Okay?
Hopefully it should be as smooth when the session's done.
Yeah, that's what I'm hoping. Test your slide.
Hey, Dr. Anand, how are you? It's Barry.
Hey Barry, I'm good.
Good. You feeling better?
Yes, Tylenol has helped.
Hold on a second.
No, I have yours. I need to know what's through.
So you're feeling better with your cold?
Yeah, I don't know what it was, but definitely it's better. Well, at least it's subsided with some medication.
Good. Excellent. All right, we should be ready to get started here in a few minutes.
Okay, yeah, no, I'm excited to chime in and hear and then see how this hybrid works.
Hi, it's Erin from Hub. I was just checking to make sure we're all set here. You guys good?
Yeah, I think so. We tested it.
Perfect. All right, I'm going to jump to another room. Thank you.
Mhm.
Yes. It is true, for sure. Yeah, I didn't, I must say, like, when I came back from Asia late last night, so I didn't cut this morning. I took a bunch of stuff home, and when I looked at it, most of the science today was all like obese stuff, so I didn't go listen to any of that, but, yeah, it is very, I've been here for, this is going on my 19th year. I came from med school, and never left all my training, and have been on faculty for 10 years, so, so it's like my home away from home. In Boston. Boston, yeah. So.
Are they not compatible with
It
each
is
other versus
a,
Red Bull?
it is an amazing institution in terms of, if you have an idea and want to try to get it done, pretty much nothing you can't have access to, you know?
They can't run out of the PowerPoint, so I can't copy and paste, that's why.
Cool.
And I probably can't.
How long have you been in the Maryland area? Since you left the military, or?
Right, well, that's what I'm trying to do.
Right.
I'm not gonna do that either.
Okay, how about this? Just keep this one in the and then we can just jump to the other contract. I mean, it's not a great solution, but
I know.
thicker again.
So I started a
Well,
program
we'll
teaching
check,
how
I needed to make sure
Uh-huh.
this video, but.
people were coming
Right.
in the military were flying here.
All around, yeah, yeah.
And then you shoot
Okay.
Oh,
kind
well,
of
I didn't realize.
people higher up, said,
Yeah.
we're gonna bring
All
everyone
right,
to
so it's a school.
Maryland,
so-
flying. We'll have a couple of centers, Maryland, Texas, California, and everyone flying to places.
Nice.
You wanna stay, you wanna practice?
You wanna do
Uh-huh.
check the clicker?
Yeah. Cool. Yeah, it's funny you said one of our fellow that just graduated last year, she's Air Force. And she, so she obviously matched in a civilian program. And they, she, during COVID, our fellows do all of the FLS teaching for the residency. And so she totally pivoted to like 100% online teaching and as proof of concept. And then we rolled it out at ACOG so that you could have like MIS people that actually know it, teach it to OBGYN residents that didn't have access to FLS instruction, right? It's some of the more needed. So I just actually have a poster that we're presenting at APCO coming up in February that's like a
Because they're gonna be sitting down to talk.
Seems like it. Sorry.
everything. I don't know. So whatever you want, we'll do it.
After we're done.
Yeah, I'm good.
Oh yeah. So I was gonna say, for while you guys are talking, I'll probably just
So
sit
he-
down here, so I'm not
so
like
he can't
behind, so
say
we can
that. He
actually
can't
watch
see
you.
you.
Do you know what I mean? Do you want me to do that? And then I'll go up after. Is that okay?
Definitely.
I get started.
Thanks. What's up?
Not able to be looking at your backside. I guess I'll see the slide here, but. Yeah, so we created this, we did this pilot, that we can, it was, what made me think of it is you saying that you flew everyone in. So now we can like get the, so cool, like get the experts to teach FLS to all these residents. And she is in the Air Force. She actually, is now teaching a med school, those interested in OBGYN, a med student class for FLS, and they can all do it remote, so it doesn't matter that she's in Vegas, you know, they all log in and get credit for her course, yeah.
It is so, because I think that's what happens, is people get excited about it, and they realize that they either want to do it or they don't.
Yeah, yeah.
It's either going to be their life,
Yeah.
yeah. Like, they don't want to.
So that way your day tag doesn't run full.
People can't stay up all night now. Hoping.
That is true. That's why I went into gynecology. I can't stay up all night long.
Everybody thinks this session is virtual.
I know. A very intimate experience.
All right, testing. Beautiful. That's great.
Is that mic? Is the podium mic going to be on though, just so I can introduce them?
Yes. What do you like to talk to on, so?
Do you want me to go ahead and get started?
I guess it's all going to be virtual.
That's right. I wonder if somebody thought this is virtual. The finance guy.
Welcome. Wow, you'll see some cool stuff.
Yeah.
Is it okay to get started? Do we have, are we good? All good? All right. Well, welcome to the breakout session. I'm Nicole Donnellan. I'm one of the minimally invasive gyne surgeons at Magee, focusing on endometriosis and large fibroids. I will say, Dr. Green and I were just joking a little bit ahead of time. My disclaimer is I don't use the robot. Maybe I'll be convinced otherwise one way or another, but I'm very excited to be serving as a moderator of this session. I'll introduce our first speaker, and then we'll come up and introduce our second speaker. We're going to hold all of our questions virtual or live in person. We have a couple people in here until the end when we can have a little bit more intimate of a discussion. So virtually, and I believe coming from Seattle, correct, Dr. Malpani, we will be listening to his talk first. He worked for a handful of years at Johns Hopkins in the domain of automated methods for surgical skills training. He was an assistant research scientist with the Malone Center for Engineering after he completed his PhD at Johns Hopkins in 2017. He then, over the past few years, is currently at Surgical Science, where he's director of data science. I just checked out some of the cool equipment at AGL that they have. His team works on developing digital tools in order to enhance the learning experience provided by VR simulators. And without further ado, virtually coming from the West Coast, thanks for joining us, Dr. Malpani.
Thanks, Nicole, for the introduction. Hope everybody can hear me.
Yes.
I will share my screen then and get going. All right. Because I can't see what's happening, I'm going to assume that the slides are shared, and I will continue on. All right, so my disclosures are that I'm an employee at Surgical Science, formerly Mimic Technologies, and they develop virtual reality simulation for medical education and training, which is also the topic for this session. So it's a quite relevant disclosure. And I think as a background, like, in addition to what Dr. Donnan said, what I kind of introduce myself as, somebody who's interested in the merger of technology and education. That has been kind of driving me forward since I joined Johns Hopkins University as a graduate student, and that kind of ended up becoming my focus area for the career so far. And I've focused in surgery specifically, developing methods for automated surgical coaching, and a lot of it was kind of focused in the domain of gynecologic surgery. Dr. Grace Chen at Johns Hopkins was one of my advisors as well for the PhD thesis. And then toward the later years of my tenure at Johns Hopkins, I started working in the other domains of like hernia, cataract surgery, and sinus surgery as well. I'm gonna use this Slido website/app for a couple of poll questions. One of them is gonna be the next slide itself. And so I'll take like a 30-second halt in case people want to load it up, whether using the QR code or this website link on the slide. And these instructions will also show up, hopefully, on the slides where the question appear. Okay, so my first question is just to gather, who all are present, either virtually or in person. And so if you can indicate that, that would be amazing. And again, you have the instructions on the left side of the screen if you didn't get on to the website yet. Okay. While other folks enter their responses, I'll move forward so that I can keep going through and be on time. And we can always look back at the responses. But yeah, I'm gonna go over a couple topics. One is introducing the whole notion for simulation-based training in surgery. Jump into a little bit of virtual reality, and then go towards how virtual reality kind of enables us to do a lot more automated training and education. And then I'll end with a short pop-up quiz to see what everybody gathered from the presentation. So I think the important question that most of you may already be aware of is, why simulation? And I think this paper from Canada kind of gives one particular aspect of it's mainly to drive towards having our trainees, our learners who are going to assist us in the operating room and beyond to be ready and be comfortable in doing this the procedures or the necessary assistance that they need to give or provide in a comfortable and independent, confident manner. And this survey kind of showed that they were like half of them, I think, were not comfortable when they reported this comfort level on different types of gynecology and obstetrics procedures and skills. And that kind of drives home the message of, we in order to make sure that the patient's safety is at the top level, we want to focus on this aspect of building their necessary skills up to a level before they start working in the operating room. And this graph kind of gives that idea of, let's make sure we have trainees or people who are learning these skills spend the initial time in the simulated environment, focusing on some of the necessary skills, so that their skill acquisition is kind of in that early stage of the learning curve is spent in simulation without any patient harm at hand. And then once they are at a particular level where we find that they would be ready and trustworthy or trustable in the operating room, that's where you would like to kick them into the operational intraoperative side of things, and then work with them on improving their skill range. Simulation is not alone going to make them the expert or master surgeon that we would want them. Of course, there has to be the component of intraoperative experience as well, but I think it can nudge them up to a point where we would feel that there won't be any patient harm, or the patient harm would be minimized to some extent. And in that spectrum of different things that you can do in the simulation side, you can start with basic skills, go on to some more procedure-specific tasks, complete procedures being done. And when I talk about simulation here, it's not necessarily only virtual reality. It's the whole spectrum of virtual reality, dry labs, animal labs, cadaver labs, and so on. And you can do all of these steps and make sure that you are kind of reaching a certain level of proficiency or competency before entering the operating room. And I think there's then the other aspect of simulation, which is that it kind of is being now used, not now, but for several years, is being used for testing and making sure that the residents are ready and can be board certified. Right? We have fundamentals of laparoscopic surgery, fundamentals of endoscopic surgery. They're both being used by general surgery programs across the country. And then, in the last couple of years, the gynecology and obstetrics programs are also mandating now, or there is a mandate to undertake FLS and pass that exam, which kind of takes them through this hands-on psychomotor skills array of tests, and ensures that they have that basic fundamentals of operating in that laparoscopic surgical modality. And then I think, there's the other pros, right? As I mentioned, their patient risk is minimal. They have all the people get the standardized opportunity to practice and test and get tested. It provides a platform for being much more objective in assessment because of that standardization that everybody is going through. And then it allows errors to occur. And a lot of focus or literature points towards that. Learning is kind of incomplete if you haven't been able to make errors and learn from them. And so the error-based learning mechanism is kind of available in simulation. And then finally, you can pace yourself, right? There's no necessary stress or time constraints that you would face if you were in the operating learning some of these skills. But there are also the negatives, right? The hospital, the educational institution has to consider the costs associated with it, needs its own space, equipment, it has a lot of consumables, human resources, people who are running the simulation center, who are proctoring, instructing the training sessions as well. And then the accessibility to expert teaching is kind of limited because you always have that expert in the operating room, right by your side, giving you live and post-operative feedback. But that kind of is limited only when those experts are available as part of your simulation courses. And then finally, the availability is also not as great. So you have to be going there when people are around to set you up. And one of the things that people always talk about is it's not real, but I like to scratch that off now in this era where there are various modalities of simulation available that we are very close to being real in whether it's animal labs, cadaver labs, dry labs, using phantoms and whatnot. So I think what I would like to next jump towards is that, where does virtual reality come? If simulation has all these benefits, virtual reality takes another step into the domain of technology and having some of those advantages that come with computers to address the limitations that I pointed out in the previous slide. And before I jump into that, I wanted to give you a very high-level introduction to virtual reality. And, what is virtual reality? The idea is that you are kind of interacting with a completely virtual world, right? Completely is important. There is nothing real that you are interfacing or interacting with. And it could be replicating an entirely new it can be replicating the real world, or it could be completely different from the real world itself. And so here is an example where it's not as realistic, but it is focused on, it has like this mix of unreal tissue, but a real instrument being used with the needle to practice basic needle passing. On the other hand, something that people also routinely encounter is the term augmented reality. And what I want to highlight is that augmented reality actually happens in the real world, right? So you are interfacing within the real world, but the real world has been augmented with computer-generated information. And you can see something in this example where you have people still standing and in the real world interacting with each other, but also at the same time interacting with these computer-generated images, which are showing anatomy in one case, muscles and things like that, and that's kind of the distinction between the two, and both are relevant for our conversation and panel today. So I think if we focus on this VR side, which is kind of where my experience also lies, is it kind of addresses many of these limitations that I talked about, that consumables are absent, because it's only the equipment that is simulating this real virtual world. Equipment is minimal. You don't really need human resources all the time. Once it's installed or once you need to do some maintenance is when it's required. And then space can be adjusted because you can have them in different form factors as well, depending on the fidelity that you want of it being as real as the tissue that you would face in the other modes of simulation or the intraoperative scenario. It is still expensive, right? And I think technology is making it cheaper by the day, as the electronics and the necessary computing hardware becomes more and more cheaper. I think the prices would also drop. They have dropped over the course of the evolution of virtual reality in medicine. And then finally, the last one is also that it is a computer program, so it is readily available. You can just power it on yourself and then start practicing. You don't really need anybody to be there for the lab to be set up. It could be just within a regular room with some access provided to the residents or to the learners to go and practice whenever they find the time to do it. And then I think the main limitation for virtual reality is the realism, right? It is not as real as the other simulation provides, whether it's animal labs or phantom tissue. Technology is improving, as you can see in these images. These are computer-generated images of different anatomical structures, and progress is being made. And so, the future towards more photorealistic simulation is quite near, as the computing resources become scalable. And I think the final thing to talk about virtual reality is that it gives you this very nice learning and educational platform, which has that, a computer in the backend. And so it can kind of start taking care of assessment. It can give you automated assessment immediately after you complete a particular exercise or training. It is objective, standardized, as we see in typical simulation settings. And then finally, it can give tools to the instructor as well to preload certain curriculum and courses, so that different trainees get different types of experiences and sequence of exercises or skills that they need to test. And this can all be done in an offline manner, so that they don't have to be there in the room simultaneously. And I think the final thing that to add is that expert teaching is still limited. It is quite minimal, and that's kind of where I found my interest in pursuing the whole notion of how do we build some automation that addresses this limitation, specifically of bringing in some expertise into the instructional platform. And so that's what I will jump into for the last section of my talk. And before I do it, I would pose another question for you all, which is, what is coaching? And I think this one, you should be able to just type in some words, and they should pop up, hopefully, here. So I will take maybe 30 seconds or so and see what people have to say. Nobody has to say anything. Ah, yes, I see some. Okay. I think, as you can see, like there's this theme of, not just being there to train or guide the learner, but to actually work with them and identify, where their potential is, to develop their skills and help them achieve that potential, I think. And that's kind of what the evolving surgical coaching community is also all about, right? There's now an academy for surgical coaching, spearheaded out from University of Wisconsin, and I think the whole concept of surgical coaching is being adopted more and more by various societies, by various initiatives and collaboratives. So I think what I did back when I started thinking about it was kind of deconstruct it into the various components, just like we saw on the previous slide of people responding to the question on what are the components that, if I were to build an automated coach, should be able to kind of answer. And those were the questions that you see on the screen on different things that a learner or the coachee would like to get information about. And I kind of club them into these different activities. And I'll do a quick roundup of this, but it is quite analogous to teaching. Whether you're a school teacher, whether you're a professional sports coach, the idea is that you want to show some of the tips and tricks and demonstrate them, what expert behavior is. Then you want to see where their current skill level is. You want to then give them some assessment, right? Not just an overall grade, but also a breakdown of their performance. And then couple that performance breakdown with what can they act upon, how would they improve, what was wrong, what led to that, maybe subpar performance or above par performance as well. And then give them some directions on what they can focus on and do as deliberate practice, and then keep monitoring their progress and have this kind of circle going on for the different skills that they want to learn and as they achieve different levels of competency as well. And then this kind of summarizes that circle, is that you want to keep going in this loop, have the trainee perform, give them some scoring, some evaluation, and then hopefully by the virtue of this cycle, the trainee is climbing this pyramid of competency and becoming as independent of a performer as we would like them to be. And then you can put this kind of cycle within the whole learning circle of going from OR to getting their performance in the OR, breaking that down into the different steps that they did, and then informing their performance on the simulator and saying, okay, you should be practicing upon this particular skill because your performance was not as great in the operating room. And then once you have achieved proficiency, you can go back to the operating room and then continue your work. And so I think that's where my final slide would be on. The way I see it is virtual reality provides us this nice technological platform to build some of these automated tools that can enhance the learner experience and provide this amazing concept of coaching for surgical and medical training as well. I think I've run out of time, so I would skip the quiz portion. Sorry about that.
Great, thank you so much. I went to share, I have a couple talks on coaching, not VR coaching, but I couldn't put my entire response in because I'm also a huge fan of the NFL and they have lots of good inspirational coaches. And in one of my talks, they have former Cowboys coach Tom Landry said a coach, because I liked that question, because it's important to know it's this, that you're guiding your learner in the constant feedback loop. And he said a coach is someone who tells you what you don't want to hear, who has you see what you don't want to see, so that you can be who you always know you could be. And I always come back to that quote with my learners too, because I think, being a coach is not easy, right? So, because we do have to tell people things that they might not want to know, but that they kind of know deep down. So. Okay, we'll hold some of our questions until the end. I would like to bring up now who's in the flesh and blood, Dr. Barry Green. Dr. Green harkens from the University of Miami for medical school, and then pivoted to Wright-Patterson Air Force Base in Ohio, Wright State University, where you did, it sounds like an integrated civilian and Air Force residency in general surgery, is that correct? And also is board certified in not just general surgery, but bariatric surgery. He was just sharing with me his interest in picking up the laparoscope from the 90s from none other than gynecologists. It's kind of weird that they were the ones that somewhat started this movement many years ago. And is currently the co-founder and CEO of Vicarious Surgical, really a company from exploring through the website, although I want to hear more, really pushing the envelope on surgical robotic technologies and development. So I'm looking forward to hearing all about it.
Thank you very much, Dr. Donnellan. And I want to thank the organizers of this great conference, Magee-Womens Center Women's Conference, for asking me to help to share some of the thoughts. They're all forward-thinking thoughts in the use of computers in helping with surgery. So it says there, I am the co-founder of this company that I started to try and help to design a robot that would have the intent of making surgery better. But the robot is not available for sale in the United States, and it's not been cleared by the FDA, so I have to tell you that. And I can't really tell you anything that's, that we're developing, so I'm going to spend the most of this time not really going over our robot, but going over the history of the robotics and the potential. So augmented reality really is an enhanced version of reality, and using technology to overlay the digital information on what we see on a screen. We'll talk about the challenges, the opportunities, the history. I think the history is really important to understand where we've been, to know where we can go. Talk about current systems, computer vision, and then predictions. And I'm going to run through some of this. These are my questions that I thought about, but I'd like to focus on the two in the bottom. How many people think that we should use computers to help with situational awareness in surgery, such as where's the ureter? Where's the common duct? How close are we to hurting that blood vessel? And then think about this as we go through this talk. How should we or could we use computers to augment our performance? Throw a needle better. Tie a knot to the right tension. How could we use sensors in our instruments to help us be better, more delicate surgeons making less errors? So this was a question I thought if we had a big clinical audience, but we'll pass through this. I think that there's been a lot of discussion in the past about suspending the top of the vagina or the bottom of the uterus to try and help better urinary function after hysterectomy. And I think that that's one issue, that if we could do this, would we do it more often? Now it's not really done that frequently, but if we could, would it be better? So how did I come about this whole thing? You know, in 1850, anesthesia started. And by 1890, really, open surgery was really taking shape. And from 1890 to 1990, there was really a revolution, an innovation in surgical techniques. If you think about it, all of stomach surgery, cardiac surgery, neurosurgery, and the hysterectomy was designed before that, but it really became into the forefront of how to do surgery with asepsis, with
decreased blood loss, and that innovation was really brought about when a single person controlled excellent hand-eye coordination, dexterity, movement, and that same person controlled the three-dimensional view. But the cost was a large incision, injuries, pain, complications from the incision, and an inflammatory response that up until the mid-90s, we didn't really understand these cytokines and leukotrienes that are emitted by the body when we cut it. So even though there was a lot of resistance with the revolution in laparoscopic surgery that occurred around 1988, we saw a marked improvement in patient outcomes, and it wasn't until we actually studied the inflammatory response that we recognized how good laparoscopic surgery was. What I noticed starting out doing laparoscopic surgery in 1990 and working on all the different organs and really pushing the envelope and studying hard, and then I started teaching, and I recognized there were some great open surgeons who didn't really capture laparoscopic surgery. So the robots came out in 2000, and I sat down on the robots, and I felt like, these robots are amazing. They allow the right hand to move the right instrument, the left hand to hold the left instrument. They gave the surgeon back the ability to control the camera, but they were limited in their ability to go around the abdomen, to see behind them. The robots would collide on the outside. They were very expensive, and they were very hard to set up. So I had the idea of making a really small robot that we could put inside the abdomen. And I told an engineer this about 12 years ago, and he started to build this vicarious robot. And what it allows for, by going through a single incision, is to see around the abdomen, to look anywhere you want to look, to move in the same orientation. And so the reason that we got focused on this was because what we're left with now in surgery is, across the world, is more than half of the operations that should be done laparoscopically or minimally invasively are not being done because of the issues with the current system. But what we need then is more minimally invasive surgery around the world. So let's take a step back and look at where the robot came through, and I'll try and blast through this for the time. But it really became, the ability to make a robot really came about when computer numerical control of machines occurred in '53. By 1960, there was a robot out there, and at Stanford, there was a lot of research done at the Stanford Research Institute, and by 1969, they had camera vision, position sensing, force sensing. And across the world, there were a lot of great centers, including Carnegie Mellon, and all the way over to Belgrade, they began using high-speed computing to program a prosthesis. So you see that even in the 60s, this revolution in computer science was coming into medicine. By the 70s, Stanford Research Institute had created a pole block arm, and across the country, with the help of the East Coast universities, the programmable universal machine for assembly, the Puma 200, was also being made, two separate competing institutions. Well, McEwen used the first robot that I can find in 1983 for a voice-activated knee positioning during arthroscopy, and during arthroplasty. And then Dr. Kuo used a Puma in 1985 to do a brain biopsy. So I'd like to take another step back and ask the question, why didn't these advances take effect, and what are we fighting today? I think it's a little bit of a fear of letting go of control. So a great doctor, Dr. Anvari from McMaster's, who's a great robotic and surgeon and a robotic innovator, has created a breast biopsy robot which is completely autonomous, and it's used in an MRI. And so when he's introducing the concepts, he talks about the levels of autonomy. So when we sit down at the Da Vinci and we use the robot, we control that. It is complete assistance. If we do task autonomy, that's like when we fire a stapler. We press the button, the stapler fires all the way out and comes back. It's doing a defined task without any interaction of the computer. Conditional autonomy is when we tell the robot to do something, and it has sensors, and we're going to watch it, and it's going to do a defined task, but it's going to change a little bit. Like when we fire the stapler on the Da Vinci, it actually senses the compression of the stapler, and it changes the pressure based upon that compression. High autonomy is like when you press the button to drive you in your Tesla, and you're sitting there at the steering wheel, and then full autonomy is if you decide to go to sleep, and it's not very smart, but the car's going on its own. So there is already high autonomy in surgery, and that is when you tell the Da Vinci robot to target. You actually hold on to the port in the Da Vinci robot, and you press a button, and the arms move without your control, based upon a program and sense of that robot. So we're using all those things. And let's back to history. In 1988, Davies at the Royal College of Physicians in London created a robot that could do prostatectomy, transurethral prostatectomy. And it used an ultrasound where the surgeon would go in and identify what he wanted the robot to resect. And then there would be a live video feed and then a schematic. So I think this is really the first use of conditional autonomy, and maybe this is the earliest use of augmented reality that I can tell, because there was really changes in this picture as the robot took sections out of the prostate. But this didn't take hold because we just weren't ready. And now there's another company who's doing the same thing with hydrodissection, and it's taking hold. So Stanford research, again, Philip Green, he created this robot in '89, and by 1991 it was a functional laparoscopic robot. Across the bay, there was Yulan Wang, who founded Computer Motion and created ESOP, which is a voice-activated camera manipulation, FDA cleared in '94. He also developed this Zeus, which was a 3-arm robot, much like the Da Vinci, but it just predated it by a few years. So there was a great lawsuit. The guy I'll talk about in a minute, his name is Fred Moll, who a brilliant overlord, but he left his OBGYN residency in '88 to create the first trocar, which was the Covidian trocar, now is the Medtronic protecting trocar, and that was his invention. And he turned that into, I guess now he's not a practicing physician, he never finished his residency, but he eventually started Intuitive, and through lawsuits he ended up merging with Computer Motion, and he banished Zeus and ESOP, taking their information. So Fred Moll, brilliant guy, I am his innovation greatly. He started in Intuitive Surgical in 1995 and ended up getting it cleared by the FDA, the first Da Vinci in 2000. So now the landscape. There's hundreds of computer companies that are working in surgery now, and a couple of them that you know, that is Memic has the Hominis, a new transvaginal single port robot. Intuitive, CMR, Transenterix, all these actually have robots that are approved by the FDA. But what has been the great advance from 1990 to now? It's still been multiple arms, and the multiple arms get in the way of good surgery. And so Da Vinci actually is, or the Intuitive is actually working on a single port because they realize the importance of the single port. And this is our, can you play those videos? I'm not sure how to do that. Just click on them. And click on the bottom one. Excellent. So we had this idea of creating a single port robot where the arms can change the perspective. It can work to the right, to the left, can work straight up and down, it can work backwards, down behind it. And the flexibility of this robot allows surgery in any position in the abdomen. And the lens is not a single lens, it's two lenses that are separated far enough apart that we can get true three-dimensional vision. And the cameras in that head are so powerful that we can use differential absorptions and actually add value because of the way the robot is, the computer inside the robot is interpreting. The other thing that's important, it has to be inexpensive and it has to be mobile so that it doesn't take on a lot of space in the operating room. I'm sorry? Measured? Oh, yeah. The trocar is in centimeters. So the Da Vinci trocar is currently about 25, 27, and we are smaller than that. Let's see. Okay. So the future is functionality. We see a lot of computers that we use in doing things that we already live in. And really in augmented reality, we can use differential absorption of near IR light. So this product, this vein sight, is about $3,000. It's available in hospitals all across the country. It simply projects IR light. It's the absorbed IR light by the vein is not reflected back. The rest of the light is reflected back. The computer sees that, and it creates a map of the veins, and it projects that down onto the skin. And what that does is allows really virtual, or rather augmented reality in every setting. Now, in this case, Augmetics is using augmented reality to help surgeons identify pedicles adjacent to the spine so the surgeon can then use the marriage of the information that the surgeon sees with the CAT scan to create a three-dimensional image. And the surgeon looks through this head-mounted display, and there's a little mirror right there that the surgeon can see through, a little piece of glass the surgeon can see through, or the surgeon can see this image projected right there in front of him or her. And it allows for much more accurate placement of screws. So that's augmented reality being used right today. Now, augmented reality has been around for a long time. ICG is a dye, indocyanin green, that is plasma bound. It's rapidly excreted into the bile. It's very safe, very inexpensive. And if you shine light at 775 nanometers, it will fluoresce back at 805, and then the computer can see this and overlay that picture. So the timeline here, it's injected 5 minutes later, it's in the liver, it's in the bloodstream for the next 15 minutes, and then it goes out into the bile. So it can actually be modified so that it can stay in cancers longer and would allow for a more easier resection the next day. And this, can you hit this one again? I'm proud of this. This is my son, who's my partner, performing a gastric bypass with ICG. And you can see here the blood vessel down here is creating a Roux-Y in a very heavy patient. And the ICG allows us to see the blood vessel so that we can create a longer Roux limb. And you can dissect, this is called the overlay mode. And you can see that blood vessel coming down here. So he can take this dissection down here and then cut across here, creating a very long Roux limb for a tension-free anastomosis. Here's an example of ICG used in biliary. Nice, simple gallbladder. Here's the common bile duct. You turn on the light and you can see the common bile duct here, but you really don't see the blood supply very well. Dissecting along to get to that critical angle, he notices a large blood vessel here and says, what's that? Is that the right hepatic or is that a large cystic artery? So he does the ICG, and the ICG is kind of, from my view, it's kind of washed out there. But I guess right there you can see a large artery, and that artery comes up here showing that that's really the cystic artery up here, and that's the right hepatic down there. So understanding anatomy is much better. Now, what about the ureter? You can inject ICG at the beginning of the case with the cystoscopy into the ureter, and then use the same scope. This is done on a robot, but you could do this for laparoscopy as well with an Ames scope. And he successfully identified the ureter in 25 patients. Moving on to ultrasound. The same technology can be used to use an ultrasonic probe and add that to the view of the surgeon overlaying it. And this is really exciting. This is a company, Peter Kim founded this company called Active Surgical. Peter Kim's a brilliant surgical innovator who started out at the Children's Medical Center in Washington. And now he's got this company up in Boston where he's using, and can you hit that, click on the video again? Uh-oh. Huh, sorry about that. It was supposed to show, oh, well, you can stop it. It was supposed to show near IR, using near IR light, just like the vein site, but having a computer superimpose that on the real tissue. So artificial intelligence can use a neural network to identify the proper answer to an equation and provide a cofactor that will allow the computer to choose the right answer. And that's how the neural networks work. It can integrate many layers of information simultaneously. With machine vision, we can recognize structures just like the facial recognition on our phone, which can allow the computer then to provide guardrails and situational awareness. So this is an example of Peter Kim's robot that he built years ago, and it's an example of how a robot can fire a needle better than a surgeon can. So I believe the future is using computers to make surgery safer. And I hope that everyone will keep their mind open to what the computer has to offer and experiment with it and allow for the data to come out over years. I think we're going to see machine guidance and warning, and most importantly, the earliest thing we're going to see in the next year, in the next few years, is going to be telecollaborating, as Dr. Malpani has talked about before. Thank you. Questions, I guess.
I'll sit here with you.
Nice.
Wanna come up closer and chat with us? We'll have a fireside chat. Can you hear us, Dr. Malpani?
Yes, I can.
Okay, perfect. Did you have questions? I have lots of questions, but.
You go ahead, you start.
So what a couple questions I had were focused on. So I'll play the devil's advocate of being a non-robotic surgeon, but both from the simulator education as well as real life implementation is obviously the cost, right? So a lot of times, as you both alluded to, it's not. I'm gonna take that. Sorry, they're miking me up. Thank you. Okay. The cost is not trivial. What do you see, obviously market share, we were talking a little bit before this, it's a lot more competition, but both from, opening this to both of you, what do you see as pros moving forward of dropping down the cost? I'm just thinking about, for instance, we did buy a Mimic simulator for $130,000 X number of years ago, and if I had to go to my to my people and say, well, wait a second, I just tried this thing out at AGL and I think I found out it was $75,000, right? Which is still, we are a fairly affluent OBGYN residency, but what might be some other things or drivers that could drop the cost of that and leading into real surgery costs too? Either of you.
Dr. Malpani, you want to go first and talk about the cost for education?
Yeah, I think what I can add is, it's definitely that has been the main bottleneck for the adoption of virtual reality simulation in surgical education or medical education. I think there have been some creative approaches towards reducing the cost, but as I think there'll be like a balance between, as we innovate more advanced computer graphics technologies to simulate in a more realistic manner the tissue, its deformation, tearing, burning, those kind of effects, it will drive the cost up. But I think at the same time, the cost for doing some of the more basic training, which I think really should be done in this computer generated environment, like learning FLS kind of skills of picking and placing, tying some knots, doing like just very early, maybe like, later senior medical students, first year residents, those kind of audiences can really benefit from them. And that cost, I think, will keep dropping because the room for innovation in terms of these, advanced technologies is limited. I think the room there is for the growth of data and analytics to build, just like we see in many of the online learning platforms, whether it's Coursera or whether it's sports learning. You can see that kind of advancement coming in and addressing a lot of those issues that are coming in the way of that adoption of virtual reality kind of training platforms in that early phase of learning. The cost for that later stage of learning, I think, will initially go up as that advancement happens, and then see like a downward trend as that kind of saturates.
Well, I think that's a really good point, and I think that the cost of education is tremendous, but the benefit of education far outweighs the cost. So that if we could provide, if we could reach a competency earlier, we would have surgeons going out doing surgery that have lower complication rates. And we all agree that minimally invasive surgery is better. So if we could eliminate the complications of open surgery by doing more minimally invasive surgery, then the benefit to society would far outweigh the cost, even if we were able to put these $150,000 trainers at every center in the world.
Yeah.
And then if we talk about the cost of the robot, I realize that the cost of the robot has limited the adoption around the world. So I think that what we need is more competition, more companies to come out into the market and provide the world with Yeah.
Treasurer of the Research Institute. I serve on the UPMC finance committee, right? So, and I know over time, like over years, when they've looked at surgeons and how they approach like a knee replacement, right? Who does it in 60 minutes when who takes 90 minutes, and then efficiencies, right? Try to coalesce. That's the same thing like with a robot. But I think the other thing is with the virtual reality in terms of the business model of the robot. Is it like fee for service, right? Is it like a subscription model in the VR world versus, just like any other software versus the robot? Is it like leased, right? Or how you use it versus you have to buy this large piece of equipment?
What's that? Oh, so the business model can really morph to what the industry needs. But I'm keeping my eye on the end result of doing better surgery resulting in lower complications, which for society, it really can save the cost. So for instance, if you look at an abdominal wall hernia, how many people live with their abdominal wall hernia that they get, and it gets bigger and bigger because they're afraid of having it fixed or they can't afford the time off of work? So if we were able to do that minimally invasively, we might have lower recurrences, less cost to the healthcare industry, and that cost savings from a better procedure would more than easily justify the cost of the robot. And the same, please help me, the same might be true for doing hysterectomy in patients that have low-grade cervical cancer. Is that a significant benefit to do that minimally invasively?
Right. Yeah. No, for sure. I think one of the things that the concern becomes is whether it's laparoscopic or robotic is how much do we use technology as a crutch, right? So it is an interesting segue here between the education and then the actual implementation. And I was thinking about that too when you had mentioned using for situational awareness the technology. Those of us that have trained and know the anatomy well, we can probably learn any technology and pivot to that.
Yes.
But how do you ensure that a general graduating OBGYN resident isn't going to use certain technologies as a crutch, right? I mean, you could say it's a safety guard, right? But if they can't find the ureter already a lot, right? There's always the jokes about OBGYNs not finding the ureter. And then they're going to have this quote unquote crutch of saying, okay, well, it's okay because this technology might help me. I mean, I suppose you've shown some good data that that they can fire that needle or nail better than a human being can. But I think that somewhat becomes, where's the line between how much do we need to educate before we empower them with technology that might be scary in some hands too.
That's a very good point, because if we don't have the basics
Right. Yes.
through simulation and robotic training, then we'll turn out physicians who may not be competent when the techniques, when the robot fails, when
Right.
something happens and the lights go out, or they're in a situation where they just can't use the robot. So that's an important thing.
Wanted to add to that, and I think the main another aspect to look at it is that if you have the technology that can do this, you can use that technology also to then educate at a much universal or global level, right? Where you won't have the necessary experts available to teach some of this more complex nuances. And so if you can embed or have the technology learn how to identify these things, these structures, it can be a useful educational tool. It can be converted into a useful educational tool where somebody can be, doing like a tele-mentoring or tele-proctoring for that.
Right. Well, that's a really important point, because if right now, here in the big city, There's always someone around in the operating room. But what about all the people around the world who are isolated, the surgeon who's working on their own, and they run into a trouble? Now, if they have this robot in their operating room, they could put out an instant message that says, can I have some help? And if we have a cadre of hundreds of surgeons across the country that are experts as part of the society, then someone picks up the thing and says, okay, and they go on their computer, and because of technology, they can see what the surgeon sees and says, well, okay, let's take a look back. Show me back here. And they can walk them through, and even for just the comfort level. I mean, I remember when my mentor would come in and kibitz and tell me what to do, it was very comforting. I think that the idea is the end result has to be safer surgery using the available technology that we have.
Well, I think that's where one of the, thinking of business and finance element of it, a huge thing as a medical educator, right, is that we currently don't get paid for a lot of what we do, right? So, I mean, I can sit with FLS box trainers with, my residents, and that's time that's taking me away from seeing people in the office or it's just nights and weekends, right? So it's just fascinating to think about some of the applications, even what you just said of kind of phoning a friend, but setting that up nationwide so that the experts can be accessible to the at-need residency programs too. Dr. Green and I were talking a little bit before, Dr. Malpani, about myself and my fellow that rolled out a virtual FLS training program through ACOG, so that basically we had 15 or 16 quote-unquote experts that were FMIGs, like fellows in MIS and or young attending. So it's CV builders. It was volunteer work for them, but as a junior faculty or a fellow, this is what you want to do. And you can then get access out to the community that needs it, and that's obviously alleviating a need to have a faculty member do that at your institution. Or then ultimately you can translate that into some sort of VR coaching, that's even better, right? If you can eliminate the human being from the entire equation so that they're getting almost as good instruction. I think that's part of a business model that would say, yes, even though this costs $60,000, if this is more time that Nicole Donnellan can spend in the OR seeing patients, UPMC, you should probably buy it, right? Because she doesn't then have to have the face time in the sim lab with her residents, which is not revenue generating. So,
Right. It looks like we may have a question from the audience online.
I don't know, it says, live stream
Oh.
at 6:15. I don't know what time it is. We have 5 minutes. Any other questions you have from a finance standpoint?
No, I just think it looks like both companies one's a Swedish company, is that right?
Yeah.
Yeah.
Ah,
And the other they're both recently public?
we're Boston, yeah. We went public in September.
You're in Boston?
Yes, we started it with, I told the idea to an MIT student when he was just before starting MIT.
Okay.
And so he built the first prototype while a student at MIT.
Wow.
So that's
So
great.
it's being used in Europe, not?
No, we're not being used at all. Yeah, we're still in development. I think that it says on the website we're going to the FDA in 2 years. We've been granted breakthrough designation by the FDA for the technology that we have to date. So we've got to kind of finish it and get it to the FDA as a completed product. But it's very exciting. I would say this is probably the most exciting thing next to having children that I've ever done. Yes.
Raise funds and you just no earnings.
Right. But it's really amazing. We now have 140 people working in an office in Boston, all engineers working on developing this product. It's crazy.
We're out of Boston.
Well, we started in Cambridge, and we've just moved to Waltham.
Oh.
My son is looking at Boston College.
Right down the road.
Chestnut Hill.
Yes. Well, this is,
Any other final comments? Dr. Malpani, do you have anything else to add?
No, I think your last comment was pretty spot on about the need for combining the various modalities of training and intraoperative devices that we have, and filling in those gaps with a virtual presence whenever it's best suited for the need of the learner or the surgeon.
Mm-hmm. I was just thinking right now is my residents this cohort of residents, they kind of are laughing at us because they have survived a pandemic. Say someone just entered into residency and now there's a once in a lifetime pandemic, right? That surgical volume went down and was taken away. And now they're now surviving a once in a lifetime hospital staffing crisis. They're like, I don't really believe anything that you're saying because we've had 2 once in a lifetime events. So this really resonates with me right now in terms of how much I played around with one of the VR things at AAGL the other day, and just how much more real things have become in the past. I mean, the technology is just impressive in the past 10 years from something I remember playing on, when I was a young faculty or trainee myself. And the cost, even when you said the cost of what that would have been 10 years ago is twice what, even though it's still expensive, the $70,000 or $80,000 piece of equipment. And to think, can this help supplement, especially in these times of need, that my residents are freaking out because we're having to cancel our OR cases right now, is huge.
These kids are going to come from a VR world, and
Yeah.
from gaming to it translates right over to
right.
Absolutely, yeah.
Now, I have one question for Dr. Malpani. Are you collecting the data across the internet from students to see how the, sort of feedback loop on how the teaching is going? Or would that be an amazing project
That would be a
for
cool
you to work
project,
together?
yeah. my wheels are spinning.
Good.
So I think I can briefly, it may spin off into its own panel, but I think we do collect data from our platforms that are connected to the internet, and we get great analytics, and we provide those back to the end user and to their program directors as well as part of one of our products, which is on the web, like a web portal. And that has kind of kicked off this whole area of having this learning management system, but focused much more on your surgical skills and your surgical skill portfolio, if you may.
Great. Thank you.
Well, thank you so much to both of you for your time. I know Dr. Malpani will still be hearing from me in all our emails back and forth over logistics. Now I'll have my brain turning. I know Grace Chen well too, so she's lovely.
2 more stocks to put on our watch list.
Yes.
Well,
Thank you so
everybody.
much for having me.
Have a
Thank
great
you.
night.
Have
Thank
a good
you.
evening.
Bye-bye.
Well, thank you.
Well, I realize this will be a dinner time conversation, but I want to know more now about your son being your partner. That's what I decided I wanted to hear and all of that.
Yeah.
Really?
Yeah.
That's really cool. I told her not to go into surgery, but the kids, they didn't listen to me.
Of course you didn't.
I told them to go into anesthesia. It's a very hard one.
Did he, is he military also, or did he? No. Now, did he join you, or did you join him when you, because you were in the military, you were,
So I was in the Air Force and I got out in 1994.
oh, so you've been over in civilian practice for a while.
So, these guys just did birthday parties and soccer games and all that stuff.
You still wanted to